While working your shift, you get called into a room for an opioid overdose, or is it? You think that there's something a little off and you wonder, is this a xylazine overdose?
And then the EMS alert goes off for a number of injuries at a nearby protest. And you wonder, what kind of injuries should I be prepared for?
In this episode of Critical Decisions in Emergency Medicine, we'll talk about xylazine overdose, specifically how to manage it and recognize and manage the related wounds.
We will also talk about protest injuries, what type of specific weapons and associated injuries that you have to think about, in addition to standard traumatic injuries that we may be concerned about in crowds.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
This is the May 2025 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss the Critical Decisions publication, which are 2 lessons of bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features such as the Clinical Pediatrics, the critical procedure, as well as lots of pearls in our drug and tox boxes.
So for our first lesson of this issue, Patch Things Up, Managing Protest Injuries, thank you to Drs. Satya Vidula and Gregory Jasani for writing this article. It's definitely an important and timely topic. Unfortunately, protests have been increasing more and more, and it is our job to know how to care for patients who are coming in from protests.
Absolutely. While a lot of the injuries may occur from these anti-riot weapons that are supposedly less lethal or non-lethal, injuries can occur and sometimes much more severe than intended. And so when we talk about these type of potential weapon-related injuries, we're talking about kinetic impact projectiles. Commonly, we talk about rubber bullets, mucosal irritants, or also commonly referred to as tear gas and pepper spray, or conducted energy weapons like tasers.
All right, let's start with this kinetic impact projectiles. What's that and how do we manage that?
Yeah, these category of weapons really range from rubber-coated metal bullets, pure rubber bullets, wooden batons, small pellets, foam tip rounds, as well as beanbag rounds, which I think is quite a misnomer because it's actually fabric filled with small lead shots. Regardless, they're meant to be, of course, projectile, and they're meant to be fired at a medium range where by the time the round impacts the individual, it should not cause significant traumatic injury. But because these projectiles are large in size, sometimes their flight paths can be quite unpredictable. And the other concern is when these are actually fired at close range, they of course have much higher energy at impact. And if they're striking the individual on a more significant part of the body, such as their torso or even their head, that can cause, of course, much more severe injuries. So there has been a lot of cases reported with ocular and head trauma. And if those patients are presenting to your ED, we certainly should think about imaging. They may even need something like a lateral canthotomy if there's ocular injury causing ocular compartment syndrome. And there's also even been cases reported where penetrating injury can occur from these projectiles.
Oh, wow. Definitely not as benign as they are made to sound. What about mucosal irritants?
Yeah, we commonly think about these as tear gas and pepper spray, as I'm sure we've all seen, whether it's news reports or heard of cases like this before. These are actually aerosolized powders and solutions that are aimed to incapacitate the targets by inflicting pain. And there are several chemical compounds that are outlined in one of the tables, table 1 in the article. But the common thread through all of these compounds is they cause a lot of eye irritation, and that can cause lacrimation, blepharospasm, conjunctivitis, eyelid edema. They can also cause respiratory tract irritation, so maybe dyspnea and cough, or even in severe cases, bronchospasms, nausea and vomiting if there's some sort of oral exposure, and of course, contact dermatitis if there's skin exposure. Generally, these are transient, self-limited effects, and so we do want to remove the individual, decontaminate them, If they're arriving to the ED and they still have a lot of eye irritation, we want to irrigate with water or saline, removing their contacts if there were any. You can also use proparacaine to add to the anesthetic effect to help facilitate the irrigation of the eyes. Don't forget to do a thorough ophthalmic exam, including a slit lamp, to look for corneal injuries. Similarly, if there is skin exposure, you can just wash it with soap and water. If the skin is intact, use saline if there's any sort of skin breakdown. And those who are presenting with respiratory symptoms, they certainly may need bronchodilator treatments. Laryngospasms is quite rare, but something also to consider.
Definitely a variety of target organs. Any special considerations for healthcare providers?
Yeah, definitely. Since these are aerosolized for our EMS colleagues at the scene, certainly they have to be cognizant of where they're staging themselves, not only for their vehicles and their team and such, hopefully away from this gas dispersion area. They also hopefully are wearing PPE to protect themselves. And then for the patients, when they arrive at the ED, we want to think about any sort of decontamination before, of course, bringing them into the facility and hopefully in a well ventilated area.
Let's talk about conducted energy weapons. What does that mean?
So these are devices that use directed electrical energy to subdue the targets. So we generally think about tasers, but these also include electrified batons. So tasers, these are devices that essentially fire these probes that have a fishhook barb that will then embed into the target to complete a circuit for a current to deliver in the body. And that would cause involuntary muscle contractions and cause the patient to be incapacitated and fall to the ground and, of course, experience pain. A standard discharge from one of these devices usually lasts about 5 seconds, but this can be extended if the operator holds down the trigger. And the older models usually only fire one pair of probes at a time, so once it's fired, it cannot be used again, but the newer models have a double shot capacity. When these devices are used to target non-vulnerable areas, maybe their limbs and such, they rarely cause major or permanent injuries. There may be some small electrical burns at the site of the probes. Rhabdomyolysis is a theoretical possibility, but generally has not occurred in healthy patients based on some of these studies. But the part that we don't know is that the adverse outcome that can occur with patients with a lot of medical comorbidities. And I think the one that we talk about sometimes are, of course, cardiac arrhythmias and that risk. And don't forget that in addition to the injury that can potentially occur from specifically these electrical energy delivery, there can be secondary injury from the patient falling to the ground.
Makes sense. I don't think I've ever really thought about asking about a fall to the ground afterwards. Let's talk about needing to remove these taser probes. Any thoughts on how to do that?
So it really does depend on the model of these probes. The older models, you can just simply pull upward at a 90-degree angle to remove them, despite the barb-like hook to them. The newer models actually have specialized removal devices. I've never seen one of those, but I suppose it's good to be aware of where to find one.
Learning something new every day. So, what are other injuries that we should be aware of?
So, of course, these protests do involve oftentimes crowds. And so we do have to think about other things that can be used as weapons that are carried or thrown at individuals. There may also be dogs that are used by law enforcement or even protesters, and crowd related injuries like trampling, and of course, environmental exposures, whether it's hypo or hyperthermia.
Well, thank you, Wendy, for going through this very important topic with us. And thank you again to the authors for writing about this incredibly important and unfortunately timely topic. In patients coming in from protests, we got to think about kinetic impact projectiles, so things like rubber bullets and so on. We need to think about the fact that if they are shot at a close range, especially with the eye, we need to be worried about ocular compartment syndrome, and that penetrating injuries may actually occur, although that's not the intention. With mucosal irritants such as tear gas and pepper spray, they can cause irritation and injury to the eye, respiratory, and if there's any oral exposure, nausea and vomiting, and dermatitis. And it's incredibly important that we keep our healthcare providers safe from that as well, because if you're not wearing enough PPE, you can get contaminated, especially if you're not in a well-ventilated area. Conducted energy weapons include things like tasers. An important thing we got to remember is, other than the actual local injury from the barb itself, is that the impact can cause a fall to the ground with resulting additional injuries. It's important to know the model to be able to take out that taser probe with as minimal additional injury as possible. And then we got to think outside of the box that there are other injuries that can occur on these protests, such as just general injuries from items being thrown around, or dogs, or environmental exposures as well.
Thank you, Danya, for the summary.
Well, moving on to our critical ECG this month, we have a man who is coming in with chest pain and noted to be tachycardic. He was noted to be in atrial fibrillation. They were thought to have right bundle branch block. And then you're looking at the EKG and thinking, hey, is there an ST elevation in the anterior leads? And is this coming from the right bundle branch block? A couple of things, and obviously pictures are worth 1,000 words, so take a look at the images that are very well explained. Remember that right bundle branch block adds considerable difficulty to the ECG interpretation. However, it is not typical for right bundle branch block to have ST elevation in V1 to V3. So if you see that, there's something else that's going on. In uncomplicated right bundle branch block, you're going to see possibly delayed right ventricular conduction if it's complete with a widened QRS, but also you may see ST depressions and T-wave inversions in the right precordial leads. That is part of your right bundle branch block. The rest is not. And remember that if you have a new right bundle branch block and somebody who is coming in with a STEMI, like this patient in this case, then this patient is more likely to have complications such as cardiovascular complications, complex coronary lesions, larger infarct, and death. Our clinical pediatrics this month is a child who's coming in with seizures. It's a case of a previously healthy child coming in with upper respiratory symptoms, who comes in with a fever and a seizure-like episode, and then they're altered. EMS notices a wide complex tachycardia, which they thought was VTAC, and they cardioverted the patient. The patient comes into the ED, is tachycardic, and she still has that wide complex tachycardia, but she's now alert. She's speaking complete sentences. And you give her calcium gluconate before trying to give her lidocaine as advised by cardiology, and then she goes into clear VTAC, and you have to cardiovert the patient. Not sure about you, Wendy, but I'm already scared reading this case. So then you do the bedside echo and you notice that the patient has a depressed cardiac function with an EF of 20 to 25%, and her respiratory panel is positive for adenovirus and enterovirus.
Whew, scary case indeed. I guess we're still talking about ECGs after all. This is a good reminder that one of the presentations of myocarditis can be certainly arrhythmias. And in the acute inflammatory phase, generally we're thinking about irregular and polymorphic ventricular arrhythmias, whereas after the myocardium heals, the arrhythmias become more monomorphic and regular.
Well, myocarditis is often undiagnosed or underdiagnosed in children because they're either asymptomatic or they just have mild symptoms. And there's a bimodal distribution of children younger than 5 having the highest incident of mortality. SVT is the most common arrhythmia reported, but in a case like this, patients may have a VTAC and it may not respond to medications. In these cases, definitely consult with cardiology and consider the patient early for ECMO to decrease morbidity and mortality. Moving on to our LSA review, something a lot less tachycardia-inducing, I guess. We're reviewing the article by Gottlieb et al. That was published in the Journal of Emergency Medicine, entitled Digital Nerve Blocks, a Comprehensive Review of Techniques.
Digital nerve blocks are certainly very useful in the ED whenever we're dealing with fractures, dislocations, infections, nail bed injuries, because they help not distort the local anatomy or manipulate the injured tissue. And there are several techniques that I think that we're aware of. The article specifically goes through 4 of them: the dorsal web block, the transthecal block, a volar subcutaneous block, and a circumferential ring block. So the dorsal web space block is pretty commonly used Generally, you just inject anesthesia into the web spaces on both sides of the affected digit to target both the palmar and dorsal branches of the common digital nerve. It provides really good anesthesia to the dorsum of the finger, but distal coverage can be incomplete, so you may actually end up needing to give a third injection in that site. The transthecal block, or also known as the flexor tendon sheath block, you're injecting anesthesia into the flexor tendon sheath along the proximal palmar digital crease. This, of course, reduces the number of injections needed, just a single injection, but there is a slower onset of the anesthesia and can actually cause some post-procedural pain at the tendon sheath. In terms of the volar subcutaneous block, you are injecting anesthetic into that subcutaneous space of the palmar surface, and there's a pretty rapid distribution of the anesthetic, so you'll get pretty fast onset, but there's less effective dorsal anesthesia. And then for the circumferential ring block, you're talking about using a 3-sided or 4-sided ring block for thumb or great toe injuries. And these, of course, improve coverage of the anesthesia, but there is a small risk of increasing compartment pressure if you're using a 4-sided block. So generally, a 3-sided block is preferred.
A great summary of a great article. And keeping up with procedures, our critical procedure this month is about tracheal suctioning. We see a lot of patients in the ED who may have had a trach or they're intubated, and we need to suction them to clear their secretions to improve their oxygenation. And sometimes we take that a little too lightly, but it's important to keep in mind that it can transiently increase the intracranial pressure, trigger vagal response that can lead to bradycardia and hypotension, as well as causing mucosal injury to the trachea or respiratory tract.
So, to do the procedure itself, certainly patients on the ventilator often comes with the attachment of a pre-measured suctioning catheter, so that makes it easy. But you can, of course, do it with a separate suction catheter as well. Ideally, you like to pre-oxygenate the patient before you suction them to give them a little bit of reserve. If you are using a separate suction catheter, you want to keep an aseptic technique. And if you're using, once again, a separate suction catheter, you have to pay attention to how deep to insert the suction catheter. You really don't want to go past the carina. When you're withdrawing the suction catheter, you can rotate it slightly and begin the actual application of the negative pressure for suctioning. And you do want to limit the actual suctioning time to no more than 10 to 15 seconds. In terms of selecting a suction catheter, you want to use one that is less than half of the inner diameter of the ET tube or the trach. And so there's a pretty simple formula. If you wanted to refer to it, you would take the size of the ET tube or the trach minus 2, multiply that by 2, and that is the size of the suction catheter in French sizing. So for example, if you have an 8.0 ET tube or 8.0 trach, minus 2 is 6, times 2 is 12. And so that means you would need a 12 French suction catheter.
Look at that. We learn math and French on critical decisions. So our critical cases in orthopedics and trauma this month is elbow pain?
Yeah. It's an 18-year-old who fell from a skateboard and braced for his fall by putting his right hand on the ground. And now he's coming in with right elbow pain. And on your exam, he does have a mild elbow effusion. There's tenderness to palpation. He's not able to extend his elbow much, and there's pain with pronation and supination. So, of course, you get some x-rays, which the AP and lateral looked okay initially. But when you look at the lateral x-ray in more detail, you find that there is a sail sign and a posterior fat pad.
Well, radial head fractures typically result from a fall on an outstretched hand or a fouche. The x-ray only has an 85% sensitivity. And in order for it to even be that, we need to have a true lateral view to visualize the figure of 8 impression outlining the posterior olecranon fossa and the anterior coronoid process. As we can imagine, patients in pain are not necessarily able to get the best views. There are some findings, though, that suggest an occult radial head fracture, such as the lack of intersection of the anterior humeral line and the radiocapitellar line with the middle 1/3 of the capitellum, the anterior fat pad sign, the sail sign, and the posterior fat pad sign, which should never ever be there, like in this case. Depending on the type of injury, That should determine the conservative versus surgical approach. In the ED, what we need to do is provide pain control, immobilization with a sling if it's a lower grade, such as 1 and 2, or a posterior splint with that if it's a higher grade 3 and 4, and refer the patients to ortho for further management. And our critical image this month is a patient who's coming in with abdominal pain and hematemesis. It's a case of a young woman who's coming in with a history of a Roux-en-Y gastric bypass, who presents with 2 days of severe epigastric pain, vomiting, and some hematemesis. She tested positive for flu A. And you're like, yeah, you know what? I'm done. Her vitals are fine. She has epigastric tenderness, no peritoneal signs. Her labs are unremarkable. However, the astute physician decided to get a CT of the abdomen with contrast to evaluate for additional pathology, such as ulcer, pancreatitis, or postoperative bowel obstruction.
Very astute indeed. And the CT showed that there is some inflammatory fat stranding in the region of the gastrojejunal anastomosis, but there's no free air. You can see an outpouching near the gastrojejunectomy site with the surrounding inflammatory fat changes, which may be a possible anastomotic marginal ulcer. Specifically in these patients, some other complications we have to think about are anastomotic leak, which can present early, an obstruction of the bypass gastroduodenal or afferent limb, which generally doesn't show any sort of air fluid levels on imaging, an obstruction of the roux limb, which leads to dilatation of the gastric pouch. There's a great diagram in this feature that shows, of course, the anatomy of what a Roux-en-Y gastric bypass is and what each of these segments are. Certainly, there are also other complications we have to think about, like internal hernias, strictures, marginal ulcers, and risk factors for marginal ulcers specifically include NSAIDs, smoking, alcohol use, H. pylori. Anytime we're worried about patients with these gastric bypasses and these potential complications, we do want to get a CT with IV contrast. And that may help us differentiate things like an internal hernia, which may show up as a mesenteric whorl sign and clustered bowel loops, or bowel wall thickening and fat stranding related to a marginal ulcer, or even signs of perforation.
Definitely a different word of pathology with that particular surgical history. So take a look at the images. They are pretty awesome. So our second lesson of this issue is called Reining It In, Xylazine Overdose. Thank you to Dr. Anthony Spadaro, Jean-Marie Perron, Luis Nelson, and Howard Greller for writing this article.
We've definitely been hearing more about this in terms of increasing use of xylazine. What is it really, and how common is it?
So xylazine is a veterinary sedative used for procedural sedation and anesthesia. It's an alpha-2 agonist, so structurally quite similar to dexmedetomidine. It has a harmful synergistic pharmacological effect when combined with fentanyl, which is usually the case. It lasts a lot longer than fentanyl, it's 4 to 8 hours, and initially we started seeing a lot of it in Puerto Rico and Philadelphia. And in some areas of the country, it's actually present in the majority of illicit opioid samples that are tested. The combination of xylazine and fentanyl is often referred to by some slang terms like trank or trank dope.
I see. So how should these xylazine fentanyl overdoses be managed?
Well, since xylazine is an alpha-2 agonist, such as dexmedetomidine and clonidine, and actually closer to structure to dexmedetomidine, it is more of a sedative and less of like causing hypotension and bradycardia than, let's say, clonidine. Interestingly, the patients who come in with xylazine mixed with fentanyl are less likely to have a respiratory arrest. That is likely because fentanyl is a more potent respiratory depressant than xylazine, and therefore they're getting less fentanyl because there's xylazine mixed in there and then less respiratory depression. Now, xylazine itself is unresponsive to naloxone, but we still need to use naloxone in these patients to reverse the concomitant life-threatening fentanyl-induced respiratory depression. And that is another important reason why we should not be using awakening as the endpoint for titration of our naloxone, because that can lead to overadministration and precipitate withdrawal. In these patients, we're even more likely to need pulse oximetry and capnography to ensure that respiratory depression does not recur or worsen. There is no specific xylazine reversal agent for human use. There are a few in animals, but they're not tested or available for our use.
A good pearl for sure. What treatments do exist for xylazine withdrawal?
Well, that's really interesting, Wendy. It is unclear whether there is an actual distinct xylazine withdrawal syndrome or not. Because xylazine is usually used with other drugs, it can be quite confusing. And patients are going to come in with withdrawal from the other substance as well as possibly this xylazine withdrawal. Now, once we treat that withdrawal from the underlying substance, most commonly it's an opioid, and the patients are continuing to complain of cravings, anxiety, and restlessness, then maybe we need to think independently of the xylazine withdrawal. Clinicians have used tizanidine, lofexidine, guanfacine, which are all oral alpha-2 agonists, to manage the xylazine withdrawal. However, there's not really any dosing or safety data. There are other alpha-2 agonists, such as clonidine, which may be helpful also in treating opioid withdrawal. So maybe that would be a more logical place to start in patients who consume xylazine with opioids, because that way you treat both in one, if this is truly a distinct clinical entity.
That makes a lot of sense. Now, what about these xylazine-associated wounds? What do they look like and why are they formed?
So these xylazine wounds typically start as dark blisters over intact skin over on the extensor surfaces of the extremities. And then over several days, these blisters enlarge or coalesce and form a large ulcer. And then the ulcer develops a black eschar over some areas, and some may retain viable tissues. The ulceration may be deep and expose muscles, tendons, and bones. The article has a very interesting image that shows the gradual worsening of a wound. These wounds may lack a classic sign of infection. However, if they're left untreated, they may develop infection secondary to compromised tissue. The cause is really unclear. Maybe there might be an element of vasoconstriction from the alpha agonist activity that causes local tissue hypoxia and injury. Perhaps the excess sedation is causing prolonged immobility with pressure ulcers. There's a lot of other postulated mechanisms, but there's no clear definitive evidence yet.
I see. So, how do we manage these wounds?
The two most important things are wound care and cessation of the drug use. Reality is, unfortunately, these two things are not that easy to accomplish. We also need to assess for acute complications such as abscesses, cellulitis, systemic infection. Sometimes it can be quite straightforward and obvious. Sometimes we need to utilize additional things like labs, blood cultures and wound cultures, and imaging to look for those underlying infections or retained foreign bodies. Management, as we said, is mainly supportive with pain control, wound care, and, if need be, antibiotics, either topical or systemic. The debridement of non-viable tissue is going to be important to allow wound healing, and that can either be with topical autolytic or enzymatic agents, or for advanced wounds, surgical debridement would be necessary. Like we said, disposition may be quite challenging in these patients because logistically, getting this wound care may not be as simple, because a lot of our patients have unstable housing. So the reality of daily wound care is not going to happen. And a lot of our patients have dual needs. They need help with their substance use disorder and for wound care. Well, places that take care of substance use don't take care of wounds. And places that take care of wounds don't take care of substance use disorders. And that is quite the unfortunate situation.
Indeed. Now, what about harm reduction practices for these patients who have overdosed on xylazine?
Well, harm reduction is a range of intentional practices aimed at reducing the negative consequences of risky behaviors, including drug use, as we're talking about in this case. I think the most obvious one that we talk about all the time is abstinence. But in all reality, many patients don't have that as one of their immediate goals in the emergency department. We can still reduce harm by getting the patients to consult with a substance use navigator or other drug treatment specialist prior to discharge, give them take-home naloxone, offer them resources in the community for drug checking, syringe exchange programs, and safe consumption sites if those are available in your community.
Thank you, Danya, for taking us through this lesson. This is an informative piece for those of us who may not have seen as much of the xylazine, but should be prepared for it, since it has been found in the majority of illicit opiate samples that have been tested. Often these xylazine fentanyl overdoses can present with severe sedation and potentially less respiratory depression, but when we're administering naloxone, which still should be given, of course, to reverse the potential life-threatening effect of fentanyl-induced respiratory depression, we want to make sure we don't use it to the end point of awakening, since that can then lead to precipitated opiate withdrawal. In terms of specific treatment for any component of xylazine withdrawal, this is difficult, but one potential strategy is to utilize other alpha agonists, potentially considering clonidine, since that can help both with opiate withdrawal as well as replacing the alpha agonist effect of xylazine as well. And the other aspect that we want to be aware of are the xylazine-associated wounds, which can occur from potentially decreased tissue perfusion, hypoxia, as well as direct potential pressure injuries. But the biggest concern is, of course, potential infection related to these wounds. And so, as we do with any sort of wounds that come into the ED, utilizing our history and physical, any sort of laboratory imaging testing to help us figure out the extent of imaging and interventions. Of course, ongoing management of these wounds are quite challenging because of a lot of these limitations that you mentioned with potential unstable housing as well as resources outpatient. And the other aspect that we, of course, have to be cognizant of in caring for these patients is trying to support them in potentially reducing their future use of drugs like these. And that includes substance use navigators, take-home naloxone, as well as other programs in the community such as syringe exchange programs and safe consumption sites.
Thank you, Wendy, for summarizing this article.
For our drug box this month, we're talking about ketorolac, tromethamine. Now, we're all familiar with ketorolac. It's a very potent non-opiate NSAID. It is now available as a nasal spray, and that can offer rapid pain relief within 5 minutes for acute pain management. As we know, it inhibits COX-1 and COX-2 enzymes to reduce prostaglandin synthesis for that anti-inflammatory effect, and you can give it every 6 to 8 hours for up to 5 days. Because of its mechanism of action, it, of course, has risks of GI bleeding, ulcers, thrombotic events, renal impairment. And so this is contraindicated in patients with peptic ulcer disease if they've had a prior CABG or, of course, NSAID allergies. The side effects that we have to be aware of are nasal discomfort from the specific nasal spray delivery, and that can present as burning sensation, but that usually resolves pretty quickly.
I guess more ways to administer the mystical Toradol that fixes everything. And last but not least, our Tox Box this month is lamotrigine toxicity. Lamotrigine is a broad-spectrum anticonvulsant that's also used as a mood stabilizer in bipolar disorder. And its therapeutic effect stems from sodium and calcium channel inhibition and modulation of serotonin activity. In acute toxicity, we would see CNS depression, seizures, hypotension, and serotonin toxicity. With chronic use, we may even see oculogyric crises. Toxic effects are seen when patients consume more than 4 grams at a time, or if the serum levels are more than 20 milligram per liter, especially if there are co-ingestants, especially if they're serotonergic. The symptoms include tachycardia, QRS and QT prolongation, seizures, serotonin toxicity signs, and obviously we'd need to do ECGs for that to see those findings. Treatment would include airway protection. If they're within the correct time frame, we'd give them activated charcoal. And then to manage the seizures and the serotonin syndrome would be benzodiazepines and potentially hemodialysis. If patients are symptomatic, they should be admitted, knowing that their peak toxicity is going to happen within 2 to 12 hours. If patients remain asymptomatic after that timeline, then they can be discharged.
The trouble with broad-ranging mechanisms.
Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope that you find the Critical Decisions publication, as well as our podcast, always informative, often enlightening, and never boring.
Reach to us on social media. My handle on Instagram is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month,
bye-bye.